of you for taking time out of your incredibly busy schedules, recognizing that there is a lot going on, both here and apparently in some place called Iowa later today. But do thank you all for making time out of your schedules, and particularly given the fact that a lot of people are coming back to work for the first time this week after the recent weather challenges that we've had here in Washington. In particular, I want to thank Murray Aiken from IMS Health for taking the time to travel to Washington today to be an important part of this briefing, and we will all hear from Murray in a relatively short period of time. You know, for months now, if not years actually, all of us have been hearing and really been witness to a lot of media attention and public focus on increasing healthcare costs, and in particular prescription drug costs. That focus has been really wide and varied. Much of it has centered on the introduction of certain new specialty medicines and biologics, things like the new treatments for hepatitis C or new immuno-oncology agents, or most recently some of the PCSK9 inhibitors, which provide a powerful new asset and tool in the fight against both cholesterol and ultimately cardiovascular disease. And in other situations, there has been a focus on older, off-patented branded medicines, sometimes decades old, where there has been little to no marketplace competition, and for which, in certain limited instances, there have been significant price increases associated with particular medicines. In fact, just to provide sort of an interesting sidebar, I joined GPHA last fall after spending the better part of the last 2 decades working on the branded side of the industry, and one of the things that I found immediately upon my arrival is the level of focus and attention that was paid in particular to the Daraprim issue with Turing Pharmaceuticals that took place in the fall. One of the things that surprised me the most in sort of starting this new aspect of my career was how much time that I spent, and all of us, my colleagues at GPHA, spent through the fall really defining the fact that Daraprim was not a generic drug, that there was a significant amount of confusion in the media, and perhaps even more so surprisingly among certain policymakers who were conflating an old off-patented medicine with an assumption that somehow it inherently became a generic medicine. The reality is that Daraprim, which is 58 or 60 years old, I believe, was approved through an NDA filing, and it is not a generic drug, nor has it ever been. So it was really that experience and a lot of other discussion sort of in the public domain, some of which we strongly support and advocate for, others of which we think require some appropriate context setting, that gave rise to the view that we wanted to put together a briefing in an effort to sort of dispel some of the myths, as we've said here, or busting some of the myths is the title of this briefing, and to ensure, as there is continued focus on healthcare costs overall and prescription drug costs in particular, that the appropriate context setting is in place so a legitimate policy debate can happen with respect to prescription medicine. In terms of this briefing, this is how we're going to propose to go. I'm going to provide some additional brief context to sort of set the stage, and then, as I introduced previously, Murray Aiken, who's the Director of Health Informatics for IMS, which I think most of you, if not all of you, are familiar with IMS's tremendous work, is going to share some highly relevant data and findings that they have published over the last several months on several fronts. And then I'm going to come back and highlight a couple of potential policy proposals that I will cut to the chase here. There is no, I think probably everybody knows, no single theory, no single policy solution associated with some of the cost concerns, both in the prescription drug space or overall healthcare costs, but there are certain things that could be done right now to enhance competition, which will free up additional resources to invest in innovation and a host of other areas within healthcare if we have the collective will to move those forward, and we will talk about some of them later on in this briefing. So in terms of generics, what are the relevant facts? Well, let me start with this, which was once very well understood. Generics drive savings. Generics do not drive costs in the healthcare system. Policymakers either need to know that or, in many instances, should be reminded of that. In fact, over the last few years, we have seen significant decreases in prices from competition, and now only even a small percentage of the 14,000 generics that have been approved over the decades at the FDA have seen significant increases. I think everyone is probably familiar with Express Scripts, one of the largest PBMs in the United States. Every year they put out, and it's up here on the first slide, every year they put out a prescription price index for branded and generic drugs, which seeks to measure inflation in drug prices by monitoring changes in consumer prices for a fixed market basket of commonly used prescription medicine. They define separate market baskets. They have one for the brands and one for the generics, based on the top 80% of the highest selling drugs in each one of those categories. For 2014, the Express Scripts Price Index found that generic prescription drug prices decreased by 20%, while branded prices increased by slightly more than 15%. And as this graph in particular shows over a longer trend line back to 2008, the generic price drug index from Express Scripts fell over 50% between 2008 and 2014, while at the same time the price of branded or innovative drugs has nearly doubled within that same time window. For that last year, 2014, as Murray will soon highlight, generic drugs accounted for 88% of all prescriptions dispensed here in the United States, but equaled only 28% of total drug spending. Think about that for just a second. 88% of all prescriptions, 28% of the total cost. I'm not aware of any other industry or a sector within an industry that can deliver almost 90% of market demand at slightly more than a quarter of the total cost in the market. It is a testimony to the success of the generic drug industry and the vision of folks like Congressman Waxman and Senator Hatch 30 plus years ago when they created the pathway that now exists. In fact, in 2014, the total level of savings to the US healthcare system was slightly more than $250 billion in both the commercial and public health sector space. The rolling 10-year average from 2005 to 2014 is slightly less than $1.7 trillion in total healthcare savings to the US system. Now, when it comes to the issue of increasing prescription drug costs, at GPHA, we have and continue to believe that market competition, as it has been in the past, will be even more important moving forward, and it is a vital tool in constraining cost growth. Fortunately, the facts bear that out as well. For example, one of the best ways to look at the effect competition has on price is to look at the historical data of generics. The strongest indicators on how much of a decrease in price a drug will see after generic entry is established is how many manufacturers will get into the market, manufacture the product, and how long the product has been subject to generic competition. Many estimates suggest that in just the first 2 years post-patent expiry, after generic entry, prices can drop by 60% or more. And if you extend that out to years 4 and 5, you can be looking at levels of price reductions in the 80+% range. In fact, it is that competitive landscape that has time and time again been highlighted as a major factor, if not the major contributing factor, to the now decade-long success associated with the Part D program, which year over year enjoys an almost 90% beneficiary satisfaction rating, while continuing to come in billions of dollars below original government estimates when it was passed. Now, all that said, I would suggest to everyone here today that there is a lot of rhetoric and noise in the system being espoused by some asserting that generic drugs, and specifically generic drug costs, are driving overall healthcare costs. That is not accurate. And if we are not careful, if we let this type of rhetoric translate into policy implementation, we run a real risk of implementing solutions that are in search of problems, as opposed to considering options that can actually address some of the real challenges that do exist in our healthcare system today. So let me briefly, before turning it over to Murray, address the issue of generic drug costs and pricing directly. What is often ignored is that the vast majority of generic products do not see significant price increases. As this analysis that TJ has put up in the next slide shows from Adam Fine, who is the CEO of the Drug Channels Institute, shows that for the second quarter of last year in 2015, 74% of all generic drugs, again of the 14,000 that have been approved and on the market at some point, saw no more than a 10% fluctuation in price, up or down. And if you actually look at those charts, the percentage of drugs that took a 10% price decrease is equal to the number that took a 10% price increase. And if you look at the ones that are on the far end, the outliers, if you will, for every generic drug that does see a significant increase at the highest end of 100% price increase or more, there are 2 times that many that sees a significant price decrease in the neighborhood of 25 to 100%. Now, for example, according to a recent article in Pharmacy Times, which referenced the work done by GoodRx, which some of you may be familiar with, it is a website that tracks and compares drug prices. 30 of the 50 most commonly prescribed generic drugs decreased in price during calendar year 2015. For a quick example, generic Prozac began the year with an average price point of $7.16 for a 30-day supply and ended the year at $5, which was a price reduction of slightly more than 30%. Just to put into context, IMS, as Murray could tell you better than I, estimates that there were slightly more than 28 million prescriptions for generic Prozac filled in the United States last year. So you can see in terms of the sheer volume and the price points that we were talking about that it generates a significant level of savings compared to the older originator branded products. And if you actually don't want to believe one of the leading pharmaceutical economists in the United States, which I would suggest to you Adam Fine is, then I would suggest perhaps the federal government's own analysis as recently as last week perhaps could be a bit more persuasive. Just last Wednesday, Dr. Richard Frank, the Assistant Secretary for Planning and Evaluation at the Health and Human Services, released a comprehensive report, a copy of which is included in the packets if you want to take one with you today, analyzing various market factors affecting the generics market. The ultimate conclusion of the report, that the market is working. Right up front, the report states, and I'm quoting, "Our review of the evidence strongly supports the conclusion that generic drug prices are not an important part of the drug cost problem facing the nation." The report goes on to provide an amazing overview of all the data that we have seen around the healthcare sector, and most notably shows in the analysis that only about 13% of drugs saw increases of greater than 20% between June of 2013 and June of 2014, which is the time period for review in the article. I encourage all of you to take some time to read it. It hits on a number, in addition to giving a great overview of the entire pharmaceutical landscape here in the US, it also identifies several hurdles that are associated with raising the level of competition even more in the generic marketplace. And again, we'll come back to talk about that after Murray's done. But things like the GDUFA backlog, extended exclusivity periods that are often proposed, and REMS abuses that are being practiced by certain limited companies. While we've seen, in addition to, just one more thing on this chart, with respect to some of those that are on the outer edges, particularly in the price increase area, the 1%, we are currently undertaking a level of analysis that shows for products in that very, very small category of outliers, that an overwhelming majority of those had an initial price point of somewhere between 25 cents and 75 cents. So you'll be hearing more when that study is finalized in the not too distant future from GPHA, because we do recognize that even though the bolus is in the middle, that if there are ones that are on the outside, we have to put context and explanation to them as well. So more to come from GPHA on that front. The reason we go into this level of depth is because as this conversation goes on, we are very concerned that we may not be paying enough attention to curbing overall increased costs where they are being felt the most, and that is in the exploding specialty drug market. Specialty drugs now account for over 30% of the overall drug spend and are utilized by only about 1% of the total population and up to approximately 3% of total prescriptions. Now, as I said in my earliest comments this morning, these are remarkable advancements. As I said, I spent a lot of time on the branded side of the industry, and I can tell you that I, for one, am as big a believer in innovation today as I was when I worked on that side of the industry. Whether it's for hepatitis C or immuno-oncology, these are agents that are saving and transforming lives, and for that we should all be appreciative. But it is also undeniable that they represent an enormous financial cost to the system, one that is only projected to get worse in future years. And that is the challenge I would submit to everyone here today that we all collectively face, which is how do we create headroom for innovation to make sure that these products continue to be developed and come to market, while at the same time creating a sustainable healthcare system from an expense point of view. At GPHA, we think the advent of biosimilars here in the US market, as many of you are probably familiar, the first biosimilar entered the market last fall. And as they continue to enter the healthcare system, we think they will provide an enormous opportunity for uptake and utilization similar to the success story of generics. And again, we'll come back and talk about that in a minute. but only if we get the policy implementation right, if we get the regulatory environment right at FDA and we get the reimbursement policies right at CMS. But since our primary objective here today is to really convey the success story that generic drugs have and continue to deliver in savings of billions of dollars annually, I'm going to now turn things over to Murray. As I said, Murray is the director of the IMS Institute for Health Informatics, and he's going to walk through some of the work that IMS has been doing of late. Murray?
Thanks, Chip, and good afternoon to you all. So just to clarify who I am and what I do. So I'm the Executive Director of the IMS Institute for Healthcare Informatics. We are a separate group that's a part of IMS Health. Our mission is to really tap into all of the data that IMS Health has, as well as the analytical abilities that we have, and apply those to issues that we think are important in healthcare. And we're bringing forward insights and perspectives into the public domain can help everybody's understanding of the operation of our healthcare system. And in that context, we have over the last 7 years undertaken a piece of work for the GPHA that seeks to quantify the savings to the US healthcare system as a result of the availability of generic drugs. And just briefly, in terms of the sort of methodology that we do, we basically look at each year at all the drugs that are dispensed through, essentially through retail pharmacies. And we look at the actual cost of those drugs and the actual mix of generics and brand versions of those drugs. We then look back at what the average cost of the branded drugs were prior to their being generics available. And we say if all of that volume of prescription had been dispensed at the brand price that prevailed before the brand went generic, how much extra would have been spent? And we attribute that additional amount as being the savings that are the result of generics being available on the market. And we've done that. We do that for the we've done that for the past 10-year period. So what this chart is showing is year by year along the bottom, the annual savings that have accrued to the healthcare system as a result of the availability of generics, climbing from about $87 billion in 2005 up to $254 billion in 2014. And that steady climb is a reflection of a larger number of branded drugs now being available as generics. It's also a reflection that a higher and higher percentage of all prescriptions go to patients as generics, 88% in 2014. And therefore, the total amount of the savings grows as a consequence of that. The total savings over this 10-year period comes in at about $1.68 trillion, so just under $1.7 trillion. On the next slide, we show how the $254 billion of savings in 2014 breaks down by therapy areas. And what this shows, again, is that the savings accrue across a very broad range of therapy areas, from mental health, hypertension, cholesterol at the top, down to some of the Alzheimer's drugs that are now available as generics, osteoporosis as well. But wherever you are on this chart, the savings are measured in billions, and this is for the 1 year of 2014. And again, it's a reflection of the availability of generics and the mix of generics relative to brands dispensed in each of those therapy areas. And what that also translates to is a magnitude of savings that we're showing here, looking in the blue part of the bar at the bottom, showing what was actually spent on drugs in that therapy area in 2014. And the incremental green is the amount that would have been spent if generics were available. And so the total length of the bar represents the total spending that would have occurred if those generics weren't available. And the red bubble is the amount of savings in 2014. So for hypertension, actual costs of those drugs was about $8 billion. It would have been almost $36 billion if generics were not available, and so on and so forth. We've also looked each year in our report at where do these savings flow from a patient perspective. And here we're breaking out the amount of savings. This is, again, breaking down that $254 billion total. How much of that accrued to seniors, which we estimate to be about $92 billion. How much to older adults, 40 to 64, $111 billion. Younger adults and children, and so on. Again, the way we're calculating this is by looking at the share of the prescriptions that are used by those different demographic groups, and then applying the savings methodology, as I've described, to those prescriptions going to those different age groups. So it's across the board. In particular, it accrues to the seniors who do utilize prescription drugs more on average than younger age groups. The savings also flow through the different types of payers that we have. The majority, 51%, accrues to the commercially insured, those with employer-based or other forms of commercial insurance, including exchanges. Medicare, the savings there represents about $76 billion, or about $1,900 per enrollee. Medicaid, almost $34 billion in savings, or $479 per enrollee. And then the small cash part of the market accounts for the remainder of the savings. So again, it's across the board. And on the next slide, we just, again, specifically looking at Medicaid and Medicare with the total amount of savings in 2014 and the average per enrollee in those programs. Let me now turn to another piece of research that we've posted recently on our website, and it's called Price Declines After Branded Medicines Lose Exclusivity in the US. And this was a piece of work we did to try to look at the longer-term pricing dynamics of generics. And part of this is because we've heard the discussion around rising generic prices. And so we sought to look at our data and see what we could find there. I should also say that this piece of work was funded by the Pharma Research and Manufacturers Association. It was undertaken independently by the IMS Institute. And what we've done here is taken the set of molecules that lost exclusivity, lost patent protection between 2002 and 2014. There's 428 molecules in that set. And we sought to look at their price levels following the entry of generics. So in this case, we set the baseline as the average price of the brand for the 12-month period prior to the entry of a generic into the market. And that represents the 0 point, if you like, on this chart at month 0. And then what we've done is track the generic pricing relative to that baseline for up to 10 years. Obviously, not all the products have been available in generic form for 10 years because our cohort was from 2002 to 2014. So the mix of molecules is different over time. But what this shows rather clearly is the magnitude of the price reduction that comes through in the first 12 months, in the second 12 months, and through to 120 months prior to the entry of the first generic. So for all medicines, and this would be the average of the 428 molecules, the price level of generics after 12 months on the market was 51% of the baseline brand price prior to the generics becoming available. And that then falls, as you can see, over time. And remember, the cohort of products year by year is shifting because of the availability of the data. But it's a fairly steady reduction in cost that reaches 77% around year 6, month 72, and then has remained at that sort of high 70s, low 80% price reduction in the longer term. We've also just called out the oral medicines. They sometimes behave a little differently than the injectables or infusible medicines for a variety of reasons. And you can see a steeper reduction in that first year, 2/3 cost reduction in year 1, 74% after 2 years, 80% after 5 years, and then maintaining at that level through the 10-year mark. And then on the next slide, we're looking, again, similar methodology in terms of looking at the price of the generics available relative to a baseline of the brand cost 12 months before the generics were entered. We've broken up the molecules here based on the year of their entry as generics into the market. And this was an effort to try to see over time whether there's been any sort of shift in the pattern here. And here we're only looking out 3 years, so for the first 3 years of the availability of generics. And obviously there's a little bit of difference and noise, and it's a reflection of the actual composition of the cohort of molecules that have gone generic. Some drugs convert more slowly to generics, others more quickly. In this case, these are all orals, but nevertheless, there's still variability there. You can see in that first 6-month period, there's a bit of a plateau, if you like. That's particularly notable in the 2011 to 13 period. One of the reasons for that plateauing is the availability of the 180-day exclusivity period for the first challenger of the paragraph 4 under the Hatch-Waxman provision, which provides exclusivity to one manufacturer for the first 180 days, 6 months. After that point, typically a lot more generic manufacturers come into the market and compete on price, and therefore the significant further price drop between months 6 and 12. That paragraph 4 challenge and exclusivity doesn't apply to every molecule, so it's a mix and it changes year by year or cohort by cohort. But you can see that that's a feature, if you like, of the pricing dynamics that we observe coming through over that first 6, 12, and through to 36 months. But I think the message here is fairly clear in terms of the overall dynamics that we observe in the generics marketplace. Generics, when they enter the market, rapidly take a significant share of the molecule sales. They come in at a significantly lower price, and that lower price is sustained certainly over the 10 years that we've studied. And all of that is accruing substantial savings to the US health system, $254 billion in 2014 alone, and is very much a part of the broader dynamics of the pharmaceutical industry, one that is based ultimately on innovative drugs that come to market, that have intellectual property associated with them, that provides protection for a defined period of time, at the end of which generic drugs become available at much lower cost and free up resources to be reinvested in the next generation of innovation. That cycle we observe in this country works rather well, rather efficiently, and it's an important part of our overall healthcare system. So with that, let me turn it back to Chip to continue. Thank you.
Thanks, Murray, for providing that context and perspective. I think in terms of the annual report that Murray referenced, again, I believe we have a copy of that as well for all of you. You know, sometimes it's very easy, particularly in talking about healthcare, about putting numbers into context. And one of the things that when this year's report, as Murray articulated, breaks down that level of savings, not only across therapeutic areas and age demographics, but also by program, both in the commercial as well as in the government space. And the net effect of the $254 billion in savings is essentially that you could cover all the costs associated with Part D, Part B, the TRICARE and the VA system, and the entire Children's Health Insurance Program, both drug and non-drug, for 2 years for that amount of money, and still have $50 billion left over to invest in other areas of healthcare or innovation, or by way of example, the recently announced cancer initiative from President Obama and Vice President Biden, just to put some things in context. I think sometimes numbers in and of themselves, we all get a little chased into them, and it's important to remember just how much level of savings can be translated into investing in other areas of healthcare. You know, to that end, at GPHA, we believe that the most evidence-based approach to addressing prescription drug costs is to reduce some significant barriers to competition in the marketplace that still exist today. I'd ask all of you to keep in mind that 88-28 statistic, 88% of all prescriptions for 28% of the costs. Well, what does that mean? That means there are 12% of prescriptions out there that are accountable for 72% of the costs. And whether we're economists or not, we all know that in an effort to try and curtail increasing costs, you have to go to where the problems are. Now, that said, I want to reinforce what I have mentioned previously, which is we have to find ways to create headroom for these new innovative specialty medicines that are transforming lives. These are things that benefit everybody in the pharmaceutical ecosystem: patients, providers, branded companies, and generic companies. So we are very supportive of the ability to continue to bring these products to market. But as we like to say at GPHA, if you have innovation and you don't have affordability, you do not have patient success. So that is one of the things that we need to make sure as a stakeholder in this discussion that we are putting appropriate context around. And we think there are several policies that are potentially for consideration currently that, while not solving that entire unsustainable trend line, that's going to take a long time here to figure out, because in many ways you could argue our reimbursement system hasn't kept pace with the evolution of science. But on an interim basis, there are additional levels of savings that can be achieved in the system that will give us some headroom and some time for that larger dynamic and discussion to play out. Next slide, please. The first is probably an issue that is not new to many of you, and that is related to the GDUFA backlog at the FDA. Currently, there are over 4,000 applications for generic products at the FDA. Some 3,400 that are in the backlog, plus the filings that have taken place since GDUFA 1 was implemented in 2012. That year, the generic industry worked with Congress and the agency to develop the first Generic Drug User Fee Act with the goal of improving the speed and timing of ANDA approvals. The reality is that GDUFA 1 implementation, I think all parties would probably agree at this point, meaning the industry and the government, has been a challenge in the first few years. Rising median approval times, total approvals declining in the first few years. The reality is that the agency had to take the Office of Generic Drugs from a relatively, I should say, smaller department of area of focus within the overall FDA and hire almost 1,000 personnel. That is not an insignificant undertaking on behalf of the agency. And to their credit, they have worked very, very hard to bring in new talent, to streamline processes, and we're beginning to see some encouraging signs with respect to that, and for that we appreciate the leadership at FDA. But the reality is that we're still not on track to completely clear out the backlog anytime soon in the near future. And certainly that was an aspirational goal back in 2012 when GDUFA 1 was implemented. GDUFA 2 will take effect in October of 2017, And I am very confident in saying, as we are in the early stages of negotiations with the agency, that their experience through GDUFA 1 as well as our experience is informing the GDUFA 2 process, because I think what everybody recognizes is that while actions taken in the engagement process are critically important, what we are ultimately looking for is resolution of applications, whether they be approvals, tentative approvals, or actually rejections. That is ultimately what's going to increase competition as opposed to responses back and forth between a sponsor and the agency. Next slide. REMS was actually created back in 2007 as part of the PDUFA process. I think many of you might be familiar with it, so I won't go too much into it, other than to suggest that as part of REMS that is associated with certain drugs when they get approved, branded drugs when they get approved through the FDA, that there are various restricted access programs, some of which are being used by a limited number of branded companies to deny access to samples for generic companies in their efforts to meet the bioequivalence standards required to get an ANDA approved at the FDA. In fact, according to an October 5th, 2015 article in Pharmalot, everybody's most noted drug company of late, Turing Pharmaceuticals, actually had an interesting quote from their director of patient access when he was asked about a limited distribution program that they had for Daraprim. And he said, and I quote, "We spent a lot of money to acquire that drug. We would like to do our best to avoid generic competition," end quote. He also noted that he would most likely block the purchase when referring to a request from a generic manufacturer for a Daraprim sample. Now, if you think about all the attention and focus that Daraprim and Turing has received, and in fact a lot of queries about whether there were any pending applications at the FDA to compete with that product, assuming they could get through the lag, the reality is that in the marketplace itself, if you have underlying policies that are permitting this type of commercial behavior of denying legitimate access and requests to samples to conduct bioequivalence, to then file a timely application and get it approved, that is ultimately what's going to lead to the competitive marketplace that we referenced that drives the levels of savings that you've seen here today. Fortunately, there is a bill in the House. It has bipartisan support. It was introduced by Congressman Stivers from Ohio and Congressman Welch from Vermont, the Fast Generics Act, that would create a clear pathway for generic manufacturers to get access to samples. In addition, as you can see here, there's been an estimate that the passage of that and a clarification of what is appropriate and not with respect to prohibiting samples from branded to generic companies would result in a level of savings of $5.4 billion to the U.S. healthcare system on an annual basis, just less than $2 billion to the federal government. So it actually scores as well. Next slide. In terms of additional solutions, some of you may also be aware of the fact that historically there have been some discussions around beneficiary co-pays in the Part D program. Sorry we didn't make it easy for you. And the reality is that there are nearly 2 million Part D enrollees that are eligible for the low-income subsidy. And compared with other areas of Part D, high-cost beneficiaries LAS beneficiaries fill more prescriptions and have a lower generic utilization rate. I believe the overall, obviously, utilization rate is in the high 80s, both across the entire healthcare system and within Part D. For the LIS population, it is in the mid-70s. And the reality is that while they are only 8% of total beneficiaries, they do account, because they have more prescriptions per month, for a significant amount of the total spend. As a result, they only fill about 20% of total Part D prescriptions. Now, the reality is, if they were incentivized through adjustments in the copay, a slight reduction in the copay for generics and a slight increase for those branded medicines in the LIS copay, you would actually be able to not only get that utilization level up to the national average. The CBO has actually projected that could save the federal government approximately $17.7 billion over the next 10 years. So every time there's another budget agreement and they're looking for pay-fors, this is an attractive, because it's a pro-market-based solution that has had some degree of support in the past, but we would argue does not get the level of focus and attention because it is based on market dynamics that occur in the commercial marketplace with great regularity. So this is something that we think the government should seriously look at in terms of driving additional savings in the program and thus freeing up some of the headroom we talked about. Next slide, please. And this brings us back to the issues surrounding specialty medicines. And the reality is that they present the largest cost challenge in the pharmaceutical marketplace. Currently, while only about 1% of patients are on specialty biologics for about 3% of the total prescriptions, they are over 30% of the prescription drug spending, and we need to, and we will anticipate introducing competition into this market as we move forward with the advent of biosimilars. The specialty trend, as you can see here, in what is projected, both in terms of actuals in 2012 and 2014, into the projections for 2016 and 2018, is where the growth is going to happen in the pharmaceutical marketplace in terms of the cost dynamic. The reality is we need to look to ways to incentivize competition in what has traditionally been a monopolized market here. Studies have shown that savings from biosimilars in their first decade on the market here in the US could range from anywhere between $45 billion over 10 years to $250 billion. If you think about it, that is a very, very wide range of potential savings across a 10-year period. Why is the range that varied? Well, the reality is because we simply don't know with only one biosimilar on the market currently. We don't know what the level of uptake will be. We do not have all the final guidance that we need in terms of things such as naming and labeling at the FDA, in terms of reimbursement and J codes, and what products will be combined under a similar code and what will not from CMS. The reality is, once these products establish their regulatory standard and threshold at FDA, we have an opportunity consistent with the uptake that you have seen in generic medicine to ensure that safe, effective, and affordable biosimilars are in the market and are a competitive alternative to these specialty medicines. And we hopefully can begin to bring the cost curve down a bit. As you can see here, what has been projected by Express Scripts is, if you will, the art of the possible if we get some of the policies right around biosimilars as we move forward. It was for that reason that last year GPHA actually launched the Biosimilars Council, which is a composition of both our current members as well as some new members who are entering the business of biosimilars here in the United States, and several of whom have had a significant amount of experience with biosimilars in Europe. Sometimes it's surprising that we don't often like to say here in the US that we look to Europe in terms of healthcare, but the reality is for about 10 years now, biosimilars have been available in Europe. Biosimilars have had over, I believe it's 400 million patient days associated with their use in European markets. And as a result of that, while respecting the differences in our healthcare systems, there's a lot that we can learn from their use and uptake in the system. In fact, I believe it was only a couple of weeks ago, there was a new study, I believe it came out of Italy, that was looking at infliximab, I think, which is generic for Remicade. And did a head-to-head comparison of the biosimilar versus the original biologic, and found the efficacy of both of those agents to be highly effective and highly comparable. So the science is there. In fact, the production, which may surprise many in terms of sort of the historical view on generics, the production costs associated with bringing a biosimilar to market are in the hundreds of millions of dollars. So you're actually seeing levels of research and investment in the science to develop biosimilars on behalf of biosimilar and generic companies that is taking them into new business ventures and requiring much greater investment, financial investment up front than arguably some would say has existed in the past. So again, another opportunity here as we move forward in direct discussions with the FDA, with HHS and CMS to ensure that we have a robust competitive marketplace for biosimilars as they ultimately come to market over the next 10 years. And I believe that is our last slide. So I will just, I will bring this to a close by once again thanking all of you for taking the time to be here today. Again, we felt it was important to try and put a little bit of context into some of the focus around and concern, understandable concern about healthcare costs and prescription drug costs. And if you have any questions, I'd certainly be happy to answer them now. And Murray, if there are any to you, we'll direct them to you. So again, thanks for coming.
You have a question right here?
Yeah. I was in a hearing related to this week or last week.
Yes.
And the lady mentioned something about lawsuits causing the drugs prices to increase. Do you know anything about that?
I'm sorry, I couldn't hear you.
Lawsuits and how they make the price of drugs increase. Do you know anything about that?
Yeah, I'm not sure exactly which hearing, but historically I know that has been periodically offered as context and rationale for sometimes the difference between the price point in the US and it's been years, but I can remember, I believe somebody did an economic study to show some of the pricing differential between drugs, and I think this was more branded between drugs in Canada versus the US and assessed that a high percentage of the delta was as a result of litigation costs. But beyond that, I can't provide any specifics to the hearing last week. I don't know, so it could be a factor. Yes, ma'am.
So you talked a lot about, needing kind of room for innovation, which I think we all know is really important.
Mhm.
We hear a lot about priority vouchers, incentives like that. What other kind of policies are remaining around that we should take notice of?
Yeah. I would think that in terms of incentives for innovation, I think if you look at the current system that we have in place now, including things like 12 years of data exclusivity for biologics, there's a reason why most of the R&D is already done here in the world. So in terms of any type of additional incentives, one of the things that we urge some degree of caution around is ultimately making sure that we don't so prolong exclusivity and intellectual property rights that we run the risk of that competitive marketplace being thwarted. So I think, it's always going to be a balance, because we like to say we're as reliant on innovative medicine as the innovators are themselves. At the same time, if we don't at the appropriate time get to an environment that's encapsulated by this level of savings, then the reality is we're going to have a generics market in the future that isn't as strong as the one that we currently have or have had that has led to this level of savings. So I know periodically there are discussions around additional incentive provisions. At GPHA, we look at every one of them individually to assess where we are. In particular, I think with the advent of biosimilars, it's important not to take an across-the-board approach with anything. But the reality is we also need to have some caution and not just assume that we have to support additional incentives for innovation, because again, if it's innovation without affordability, then ultimately the patients suffer and the system will be unsustainable. Sure. Other questions? Yes, sir.
So what are ways that you can prevent in the market from an individual hiking up the price? Because, to me it seems like it's sort of it was a market failure for if there wasn't a generic for Daraprim. So I'm wondering what kind of legislation could put forward to prevent that from happening in the future.
Yeah, I think it's a great question, because that's the unique challenge that's in front of everybody now, which is how do you address, and I would suggest to you that Turing and Daraprim are a significant outlier if you go back to the original chart, right? It's on the far end of the spectrum. What can you put in place to rectify and address that type of issue without disturbing the competitive balance in the marketplace between innovation and access, right? So, top of mind, I know that there have been discussions around things, and some things have been proposed in recent hearings. I suspect more probably later this week around sort of expedited approval pathways for generics. The reality is, and some people don't know, that there already is a system in place for first generics or for drugs related to PEPFAR, I believe, and a couple of other limited circumstances. So, there is a pathway there. One of the things, though, that we need to balance and recognize is if we're going to talk about additional expedited pathways, it's one thing to talk about a pathway and set a targeted date, right? Go back to Hatch-Waxman, everything was supposed to be approved within the first 6 months. If we look at the lag now, we're nowhere near that, right? So what we have to try and do is figure out a way that we can address these limited circumstances that admittedly have real impact on patients and providers. I think Daraprim has like 2,000, if I read correct, 2,500 patients. For them, that's a very real issue. So how do we figure that out? At the same time, we don't want to disturb the success of the generic Prozac with 28 to 30 million prescriptions per year, right? So we take every one of those incentive provisions or expedited pathway provisions and we'll analyze them individually. I think that's a discussion that's going to continue as we move forward with this focus, but it's certainly not an easy issue, because I think part of the challenge is that you've seen some business practices of late on the branded side with these older off-patented branded medicines that historically you hadn't seen before. So it's a new issue that we're all trying to work through. Any other questions, comments? All right, well, thank you all again very much for coming. If you have any follow-up questions later, please feel free to be in touch with us at GPHA. Thank you.
This thing takes a little while. I know. It's my list. Oh, gotcha. Yeah. Yeah.